Hello, I am Paolo Gisondi. I am a dermatologist in Verona, northeast of Italy. I work in the University Hospital of Verona, so I am dedicated either to the outpatient clinic for patients with skin diseases, particularly inflammatory skin disorder and psoriasis and atopic dermatitis, but also for teaching medical students, residents in dermatology. I am president of the School of Residency in Dermatology and Venerology of Verona. And it's a pleasure to stay with you and share this insight on the topic of transition. So for transition, I mean the transition from PSO to PSA, from psoriasis to psoriatic arthritis. And why this transition? Because in most of patients, according to the study, 78% of patients, firstly appear psoriasis, the diagnosis of psoriasis is made, and then after 5, 7, 10 years approximately, psoriatic arthritis is diagnosed in patients with psoriasis. This means that we, as a dermatologist, as like a sentinel for early detection of psoriatic arthritis. But since the pathogenesis of psoriasis and psoriatic arthritis share some pathomechanism, for instance, the role of TNF, IL-17, IL-23, in initiating and perpetuating the inflammatory loop either in psoriasis and skin inflammation, but also in the entasis and the joints. For instance, these cytokines are relevant for bone erosion, bone remodeling, and entaisal inflammation. And since we as a dermatologist are treating psoriasis, moderate to severe psoriasis, with biologics that are inhibitors of TNF, IL-17, and IL-23, there is a strong rationale that if we treat psoriasis earlier, we can in some way prevent the transition from PSO to PSA. Prevent totally, I think, is not possible, but we could reduce the risk of PSA in patients with PSO. There are early studies showing indeed that if we compare the effect of biologics to phototherapy, those patients treated with phototherapy have a reduced risk of incident PSA compared to those patients treated with phototherapy. And phototherapy is a treatment only directed on the skin inflammation. In contrast, biologics are directed also on systemic inflammation. There are also studies showing that compared to topical therapy, systemic therapy is more effective. Again, there are other studies showing that some target of biological therapy, including IL-23 inhibitor, seems more effective compared to TNF inhibitors in the prevention of the transition from PSO to PSA. So the message is that still some patients that are treated for psoriasis could develop PSA, but the risk is reduced if they are treated with biologics. It's very important that the treatment is continuous and also is earlier. Is early because early intervention could be more efficient in preventing the transition than a late intervention. Thank you very much for your attention. It was a pleasure to me to share with insight that of course need to be further investigated, but we are here for working on this.